The current guidelines really, the goal was to update the recommendations for PSA-based screening for prostate cancer detection. And that is because over the last 10 years since the last guidelines, there has been a number of new developments in terms of biomarkers that are used for early detection of prostate cancer, as well as newer techniques such as using MRI for prostate biopsy. For initial biopsy, PSA is still the key biomarker for prostate cancer screening and early detection. And with respect to repeat biopsy, we believe that based on the data available, that PSA should be supplemented by other modalities. For example, MRI should be considered in patients with a negative biopsy but with ongoing concern for prostate cancer. And if a patient already has an MRI and the biopsy is negative, then adjunctive biomarkers could be considered if they would influence the decision to pursue a biopsy versus no biopsy. Yes, we have blood-based biomarkers, urine-based biomarkers, and one tissue-based biomarker. Some of the blood-based biomarkers include 4K score and PHI, the prostate health index. In urine-based biomarkers, we have the Michigan prostate score, or my prostate score from the University of Michigan, and the Select MDX, Exos DS as well. And then the tissue-based biomarker, the only one that is available is Confirm MDX. One good example is the Precision trial looking at MRI. So that the data from the Precision trial really shows that MRI improves the detection of clinically significant prostate cancer. And the other significant data was from the NIH, not a trial, but a large retrospective study that showed that adding MRI to the prostate cancer early detection algorithm helps reduce the amount of low-risk prostate cancer that are detected and increases the amount of high-risk prostate cancer that are detected, which is the cancers that we want to treat anyway. I'd like to highlight a few actually. One is the importance of shared decision making. I think when you look through the entire guidelines, you discover that getting the patient involved in the decision-making process is really key. Giving them sufficient information, the power to make an informed decision is critical. And that takes into consideration their age, their health problems, and their values as they go through the screening process. The other significant addition to the guideline is how frequent we do screening for prostate cancer. In the previous guidelines that was released 10 years ago, PSA screening is recommended every other year if there's no significant concern for ongoing suspicion for prostate cancer. But in the current guidelines, we've increased that to 2 to 4 years actually based on the available data, meaning that a patient can go for up to 4 years without a PSA if you're comfortable or if you're confident that the likelihood of the patient harboring high-risk prostate cancer is low.